The validity of static lung compliance in asbestos-induced diseases. Pulmonary compliance is a measurement of the lung's ability to stretch and expand and can be viewed as an indicator of distensibility of the lungs. Static lung compliance is the change in volume for any given pressure during a period of no gas flow. Lung compliance has been used as a way to evaluate respiratory function impairment in restrictive pulmonary diseases. A reduction of compliance is seen as an early indicator of restrictive impairment before pulmonary function tests. Asbestos are tiny mineral fibers used in many industries such as construction, manufactured goods, automobile products, and heat-resistant materials. All forms of asbestos fibers are responsible for human disease as they are able to penetrate deeply into the lungs. When such fibers reach the alveoli in the lung, the asbestos fibers cause the activation of lungs' local immune system and provoke an inflammatory reaction dominated by lung macrophages. Asbestosis, better known as occupational lung disease, due to the relevancy of the disease to those who work with asbestos in the workplace. When breathing in asbestos fibers and they make their way to the lungs, it causes an inflammatory response. This inflammatory reaction can be described as chronic rather than acute, with a slow, ongoing progression of the immune system attempting to eliminate the foreign fibers. Macrophages ingest the fibers and stimulate fibroblasts to deposit connective tissue. Due to the asbestos fibers' natural resistance to digestion, some macrophages are killed and others release inflammatory chemical signals, attracting further lung macrophages and fibroblastic cells that synthesize fibrous scar tissue, which eventually becomes diffuse and can progress in heavily exposed individuals. Fibrotic scarring causes thickening to alveolar walls, which reduces elasticity and gas diffusion. Pleural plaque are the most common manifestation from asbestos fibers. Most cases of pleural plaque occur anywhere from 10 to 20 and even 30 years after exposure. When fibers enter the lungs, they can travel through the lymphatic channels, which can cause scarring on the pleural surface of the lungs. They most commonly develop on the parietal pleura, which lines the inside of the rib cage, but can also affect the visceral pleura, which lines the lungs. It is best diagnosed by chest X-ray and computed tomography. Pleural fibrosis. The pleural lining is made from a fibrous tissue allowing to expand the lungs. When the tissue becomes defensive of a foreign object, it wants to ensure it doesn't enter the lungs, which triggers an inflammatory response that causes an accumulation of fluid in the pleural space, as well as a progressive buildup of fibrous scar tissue. The pleura becomes thickened, forcing the elastic fibers to no longer stretch as it would in a healthy individual. Advanced pleural thickening may close off the space between the two layers of the pleura and encasing the lung completely, causing restrictive lung disease. As a result, patients experience decreased lung volume and have to work harder to breathe. A study was conducted with 154 male workers that was exposed to asbestos fibers in a rehabilitation facility where lung function and CT scans were performed. CT images were assessed by highly experienced radiologists to determine their diagnosis. 4 groups were then made, which included 63 individuals that had parietal pleural plaques, 39 with asbestosis with parietal pleural plaques, 10 with visceral pleural fibrosis, and 42 with asbestosis with visceral pleural fibrosis. To address respiratory impairment, pulmonary function tests were used to determine changes in lung function by using flow volume spirometry, body plethysmography, and esophageal balloon. The balloon was connected to the pressure transducer of the body plethysmography, and lung compliance was calculated. Expiration following maximum inspiration was interrupted 4 times by shudder, and lung volumes and pressures were determined. The data was then compared to reference values of pulmonary compliance for validation. Table 1 illustrates the exposure the individuals had with asbestos. They were asked multiple questions regarding themselves and the extent of exposure. Smoking status was included due to smoking and asbestos exposure collectively can increase the risk of asbestos-related diseases up to 90% in some cases. Patients that had asbestosis with visceral pleural fibrosis tended to be older, smaller, and weighed less, but differences wasn't very significant. There were no other significant statistical differences between the groups. In comparison with patients with parietal plaques, asbestosis with visceral pleural fibrosis were associated with reductions in lung compliance, diffusing capacity, vital capacity, FEV1, and maximal expiratory flow at 50%. Patients with visceral pleural fibrosis showed reductions in predicted values of FEV1, MEF50 compared to those with pleural plaques. Airway resistance, residual volume, and intrathoracic gas volume were similar in all groups. Visceral pleural fibrosis and asbestosis are the most important factors for reduced static compliance. Reference values for static compliance differ greatly. The formula for calculating reference values comes from height, age, or lung function parameters like intrathoracic gas volume. In Galecki, 64 of 154 patients had reduced compliance. In Kwanheer, 70 out of 154 had reduced compliance. In Pilesh, only 22 out of 154 had reduced compliance. With Glisson standard values, 15 out of 154 were reduced. In Urnalt, 68 out of 154 had reduced compliance. Overall, the data showed that visceral pleural fibrosis significantly reduced static lung compliance values. The data indicated that the measurement of static compliance is not sufficient for early detection of pulmonary function impairment with parietal pleural plaques, and the reference formulas are not sufficient to detect early reduction of static lung compliance in patients with asbestos fibrosis. Although not a lot of women are involved with jobs surrounding asbestos, I would like to have seen data with women exposed to asbestos with the same height, age, and lung function parameters to see if there's a similarity or difference in results. The data showed that static lung compliance is not a sufficient way to detect early reduction in lung volumes. Most of the men were in their 40s and 60s and had been exposed to asbestos greatly. I want to know if smoking increased those values of reduction, with patients without a history of smoking differed in values. Asbestos are tiny fibers that can affect the lungs in a great way. It could even lead to many diseases that could restrict the lungs from being able to fully expand, making it hard for patients to breathe. It can potentially cause asbestosis, pleural plaque, pleural fibrosis, and many others. This study wanted to find the validity of static lung compliance in asbestos-induced diseases. Unfortunately, static compliance is not an early indicator. Asbestosis and visceral pleural fibrosis did show significant decreases in static lung compliance, diffusing capacity, and vital capacity, but the sensitivity and reduced static lung measurements were inadequately low and even lower in reference values. Because asbestos causes progressive diseases, the patient will have further complications later in life and will need further medical attention throughout their later years. Questions after reading this article. Why do you think this study only included men? Why is asbestos-induced diseases progressive? Does the amount of years and intensity of asbestos make a difference to the disease processes? Is static compliance a useful tool to identify early detection of pulmonary function impairment?